Yes.
Okay. So I'm Joe Berger. I'm a professor of neurology at the University of Pennsylvania, associate chief of the MS division, and I've had a long time interest in neuroinfectious diseases, particularly HIV. In fact, a book entitled Clinical Neurovirology, the second edition, that I've edited with Avi Nath should be coming out in the next couple of months. Just a little plug. So Osler said, know syphilis in all its manifestations and relations, and all things clinical will be added unto you, meaning he who knows syphilis knows medicine. And what I plan on doing today is going through the history of syphilis, the epidemiology, the microbiology, the stages and their clinical manifestations, the effect of HIV, particularly immunosuppression on syphilis, how we diagnose it, how we treat it. So a little bit about the history. While there's been some controversy about this because of some skeletons found in England, the preponderance of evidence is that this is a disease that actually came from the New World. Unlike the measles and smallpox and TB that the Europeans gave to the Native Americans gave syphilis to the Europeans. And it appears to have started shortly after Columbus returned to Palos, Spain from the New World. It became known as the Spanish disease or the Italian disease or the French disease, depending on who you were fighting with in the wars that Charles VIII conducted when he besieged Naples. Among the people that were fighting with them were Spanish mercenaries who had been with Columbus to the New World. And from that point forward, it is a disease that runs rampant across Europe and expresses itself very, very differently than the disease that we now recognize. So by 1497, it's widespread. The name is given to it by an Italian pathologist named Fracastori. And then there's some important dates, including the fact that it wasn't really distinguished from gonorrhea until 1838 by Philip Ricord. John Hunter had infected himself with both gonorrhea and syphilis and mistook both of them as being caused by the same organism. In 1905, the spirochete is found by Schouten and Hoffman. In 1906, Landsteiner develops the dark field, and Wasserman develops the test that becomes the non-treponemal test widely employed initially in diagnosing the disease. And then in 1909, Paul Ehrlich described Salverson 606 as a treatment for syphilis. Before that, mercury was used, heat was used, a wide variety of things. And in 1913, Noguchi finds the spirochetes in the brains of people with general paresis. So this is just a picture that I took in Lima at this museum that had these very old models that were crafted in the 800s, 900s, 1000 AD. And there's evidence in these of syphilitic infection. A genetic analysis of the infections in the New World demonstrate that the T. pallidum organism is actually far more closely related genetically to the yaws of South America than of the yaws of the Old World. And I found this actually in an article I was reading yesterday, so I included it. This is a woodcut by Albrecht Dürer done in August 1st, 1496, and it accompanied a text by a physician from Nuremberg who describes this recent emergence of an epidemic in Europe of a new disease. And this was 3 years after Columbus had returned to Spain. There are a lot of very famous people that have been infected by T. pallidum and had syphilis. According to this book by Haydn entitled Pox, Genius, Madness, and the Mysteries of Syphilis, among them is Christopher Columbus, King Henry VIII, Nietzsche, Wilde, James Joyce, Hitler, Idi Amin. For sure, Idi Amin and Al Capone were both infected by syphilis. That there's no doubt about. The epidemiology, so I can only address, I was only prepared to address the epidemiology in the United States. My understanding in conversations with some of the physicians from India just before this presentation is that it's seen chiefly on the coasts and in the south in India, and that it's rare elsewhere. In the United States, a number of cases declined very dramatically following the introduction of penicillin in the 40s, but it actually started declining before the introduction of penicillin, and in the widespread use of penicillin. In large measure, that was the consequence of contact tracing, just as we're doing with COVID-19. In my country, the preponderance of the cases are indeed also on the coast, in the Northeast and in the South, and then in California and the Washington coastal regions. There's quite a distinction between the ages of people infected. So we see more cases in the 25 to 29-year group, and we see it far more commonly among Blacks and Hispanics than we do in the white population. Now, there was a time that the HIV population was disproportionately affected. That's not the case any longer. And in fact, if you look at the number of cases in men and women, this is men who have sex with women and women, you see that it's actually more common in the HIV negative group than in the HIV positive group. And that it's about equal, that is HIV positive and HIV negative in men who have sex with men. The risks include homosexuality and bisexuality, particularly in the 1970s and 80s, until safe sex was practiced. Prostitution, drug use, crack cocaine in the United States, a big risk for it, and exchange of sex for drugs. Residents in high-risk areas, and as I mentioned, much higher in the African American and Hispanic communities. The organism is an obligate parasite, so you can't really grow it in culture without there being live tissue. So the models are rabbit testes in tissue cultures, which are mammalian cells in tissue culture. It's exquisitely fragile. Somebody once told me that if you looked at the organism cross-eyed, it would die. So it's not the type of organism that's easy to grow out of things like spinal fluid. It invades the interstitial spaces and proliferates there. It's viable intracellularly, and it spreads via corkscrew motility in the interstitial fluids and hematogenously. It's got a very slow reproductive rate, 30 to 33 hours. As a consequence, you have to keep when you're administering an antibiotic like penicillin, you have to keep the levels high for long periods of time. And therefore, it's frequent administration during the day. It's 6 to 15 micrometers in length and 0.15 in diameter. Now, there are different stages of infection. You have a primary infection that usually develops 10 to 90 days from exposure. So, and that's the development of the chancre. Now, we typically think of neurosyphilis as being a form of tertiary syphilis, but that's not true. So it turns out during primary syphilis and secondary syphilis, there's a substantial amount of organisms that get into the nervous system. Now, typically, the disease is asymptomatic at that time and may be cleared in its entirety in that early stage. So high rates get the organism into the central nervous system, but only a very small number becomes symptomatic. So about 5% of the people with secondary syphilis, and more rarely with primary syphilis, develop meningitis, cranial neuritis, ocular involvement, or meningovascular disease. Far more common, by the way, if you're immunosuppressed. Then the disease enters a latent phase after the secondary form of syphilis, which develops 4 to 10 weeks after the chancre develops. And the latent phase is divided into either 1, 2, or 4 years, depending on who you read. In this particular paper, it was 1 year. The reason there's a distinction between early and late latent is that in the first year after you have secondary syphilis, the likelihood of re-expressing it in secondary form and therefore being contagious is very high, whereas after a year or 2 or 4, depending on what you want to use as your cutoff, the risk becomes very rare, and that's why it's called late latent. And then in the individual over time, you may develop forms of tertiary syphilis, including cardiovascular syphilis in 10%, usually developing 20 to 30 years later, gummatous syphilis in 15%, developing 1 to 46 years later, and late neurosyphilis, which is a general paresis and tabes dorsalis. They're the prototypes. There are other forms of tertiary neurosyphilis, and we'll talk about them. So the primary syphilis, the chancre, which is seen here on the vulva, here on the penis, develops 10 to 90 days after inoculation. The lesion's usually single, but occasionally multiple. It often starts as a dull red macula. And interestingly, these things look like they would be very painful. They're not. It's painless and it's non-tender. And it generally lasts 3 to 6 weeks with some lymphadenopathy associated with it, regional lymphadenopathy. The secondary syphilis develops weeks later, and it's the consequence of generalized infection where the treponeme spreads hematogenously, and it goes to areas where there's favorable growth conditions. So that there are areas usually where the temperature is less than core body temperature and can be modified by systemic immunity. So this is the maculopapular rash. You can see a palmar rash develop in people. You can see what's called condylomata lata. It can be confused for condylomata acuminata, but it's quite different. And then you have these mucous membrane patches that develop, as seen here in the palate and here on the tongue. And then it goes into this latent stage, which I described to you earlier. Now, the frequency of CSF abnormalities has really informed us as to how often this bacteria penetrates the brain during early stages. And these come from studies that have been done many, many years ago, where the person either had early syphilis, which is primary or secondary syphilis or primary syphilis. And you see here the number who had CSF abnormalities. Now, this was a time before PCR was invented, so although they had CSF abnormalities, the presumption was that it was the consequence of the T. pallidum, although you could argue that maybe it was something else. But control populations did not have this. And the number is as high as 48% with secondary syphilis. The numbers being examined were small, the largest being this one here in secondary syphilis, where a third of the individuals had abnormal spinal fluid findings. However, it's a small number that those abnormal spinal fluid findings persist in. So Houston Merritt, who was really a guru with respect to neurosyphilis, was the chair of neurology at Columbian Physicians and Surgeons. He said, if the CSF is normal 2 or more years after infection, it will always remain so, and parenchymatous neurosyphilis will never develop. And the point to be made here is that many of those people with primary and secondary abnormalities in their spinal fluid will have a clearance of those abnormalities and will have negative CSF VDRLs at 2 years, and they will not go on to develop neurosyphilis. The forms of tertiary neurosyphilis, or the forms of tertiary syphilis, I should say, include gummatous syphilis, which from the Oslo study, and you're probably familiar with the two studies. There's an Oslo study where men and women were untreated in the late 40s, early 50s to see what the natural history of syphilis was. And then there was another study called the Tuskegee study, where Black men in Tuskegee, Alabama were untreated to see what the natural history of the disease was. Both of them have been the subject of ethics reviews because, you know, how could you let somebody go untreated? But in the Oslo study, what they found is that about 15% of people developed gummatous syphilis. The commonest site of the gumma was the skin, but was also seen in the bone, the mucous membrane, and at multiple sites, and it may recur. Cardiovascular syphilis was seen a little more commonly in men than in women. It had a long latency of 30 to 40 years. Neurosyphilis in the Oslo study developed in about 10% of the men and 5% of the untreated women. Interestingly, neurosyphilis may develop before the age of 15 if you were congenitally infected, for instance. But if you're infected by syphilis after the age of 40, it's extremely rare to see neurosyphilis. So there's a sweet spot to develop neurosyphilis. The mortality is not insignificant. It accounted for 10 to 20% of deaths in people that were that expressed neurosyphilis. It decreased your life expectancy and accounted for excess mortality, with most of the excess mortality within the first 20 years. That is tertiary syphilis in general. Merritt had a classification of neurosyphilis: asymptomatic neurosyphilis, where your spinal fluid's abnormal, but you have no clinical symptoms or signs; a meningeal form that he broke down into cerebral and spinal; a vascular form, again, cerebral and spinal; parenchymatous form, which included paresis, tabes, optic atrophy, and a chronic polio; and a gummatous form that could be cerebral and spinal. And these aren't necessarily mutually exclusive. So what we see is this spirochetal invasion of the central nervous system. In many patients, if not most, there's a spontaneous regression. Some have asymptomatic syphilitic meningitis. Some of those go on to develop symptomatic syphilitic meningitis. And of both the symptomatic and asymptomatic, they can develop meningovascular syphilis and these other complications. If you look at the relative frequencies of neurosyphilis, now, mind you, this comes from 1932 to 1942, and it comes from Merritt's experience with nearly 700 patients. And I must say, it's quite different than my own experience. I can't say that I have 700 patients that I've seen with neurosyphilis, but I've seen probably a couple hundred, and my experience is vastly different than his. So asymptomatic neurosyphilis accounted for 31%. I would say that asymptomatic neurosyphilis is probably the commonest form that I've seen. Tabes accounted for 30%. In my lifetime, I've seen 5 Tibetic patients. I'm going to show you one in a second. General paresis accounted for 12%. Again, a very small number of patients in my experience. A combination of tabes and general paresis in 3%. Vascular neurosyphilis, which in my experience was far more common than in his, was 10%. Syphilitic meningitis, 6%. Again, far more common in my experience. Now, my experience has been in some way biased because when I lived in Miami between 1978 and 1994, HIV was raging there, and we saw a lot of neurosyphilitic patients who were co-infected. Deafness in 1%, optic neuritis in 3%, meningomyelitis in 3%. And I've seen a number of patients with spinal cord disease that is not tabes. Actually, I find it more common than tabes, and 1% in others. This comes from the Oslo study, where meningovascular syphilis was more common than the other forms, and neurosyphilis in general was more common in males than females. And this comes from the Tuskegee study, which were all men. And the numbers were small, but you see that 4% of them at 20-year follow-up had developed neurosyphilis. This was a patient of mine with syphilitic meningitis. This was actually, I shouldn't say a patient of mine. This was a patient that died in the emergency room, came to autopsy at the University of Miami. And this was the meningeal infiltration that was seen. Cranial nerve involvement is not uncommon with syphilitic meningitis. The commonest cranial nerve involved is the 8th, followed by the 7th. But you could see any cranial nerve involved. The 11th is the least common. Optic atrophy is seen. About a quarter of the people with syphilitic meningitis may have optic nerve involvement, and this is optic atrophy that followed on the heels of syphilitic meningitis. This is a case that I found in the New England Journal, so interesting that I think it's worth talking about, particularly for those of you that don't see much syphilis. So this man was 50 years old. His chief complaints were cloudy vision, hearing loss, and unsteadiness. 10 months earlier, he presented to his physician. He had been diagnosed with HIV. 6 weeks earlier, he had mycobacteria avium intracellularity with adrenal insufficiency and suspected iris. He presents with cloudy vision in both eyes. The visual acuity was 20/25 to 20/30. His pupils were reactive, and there were keratitic precipitates of the cornea with a few cells in each chamber. 5 days later, he has hearing loss with posterior synechiae seen in both eyes, anisocoria, and a relative afferent pupillary defect in the left eye. He also had a skin rash, and this was the skin rash, this erythematous scaling plaque over his palms. This is what the keratitic precipitates looked like in his eyes. And he proved to have syphilis. So it is something that you have to keep in the back of your mind when you're seeing somebody who may have a uveitis or a peculiar skin rash. Meningovascular syphilis is interesting because it involves very often small or medium-sized vessels. When it involves medium-sized vessels, we refer to it as Hübner's endarteritis. When it involves small vessels, it's Nissl Alzheimer. Now, some of you may have been raised in the era where when you read the neurology textbooks, and I remember that the Victor and Adams textbook at one time, the first and second editions at least, had pages, 2 pages of eponyms associated with brainstem strokes phenomenon, like Millard-Gubler, Foville's, or Nothnagel, where there were discrete lesions in the brainstem. These eponymous syndromes were first named in the 1800s by neurologists that were seeing people that had syphilis. These were syphilitic complications where a small vessel was involved and there was a discrete lesion, as seen here, a Wallenberg syndrome. We don't see these things very often anymore when people have brainstem strokes. Instead, what we end up seeing are patchy infarcts of the brainstem and cerebellum that occur as a consequence of atherosclerosis, not the clean lesion that occurs as a consequence of one vessel being involved. This was another patient of mine from Miami with a middle cerebellar artery infarct that occurred as a consequence of syphilis. General paresis of the insane, GPI, it's unclear where the name arose. There's a very nice book by Alan Roper called How the Brain Lost Its Mind. It was published last year, and I recommend it to all of you. A lot of the book is devoted to the dementia of neurosyphilis. It was, according to Allen, one of the most common causes of insanity in the 18th through the 20th centuries. In some populations, it involved 10 to 20% of the population was infected. In 1943, in the United States, there were over 500,000 cases of syphilis. So that was roughly 0.4% of the population. So a not insignificant number of people had syphilis before the introduction of penicillin and contact tracing in the United States. It wasn't until 1822 that Antoine Bell found meningitis in 6 of his patients with general paresis of the insane. It was not clear what caused that disease. In 1905, Sheldon and Hoffman discovered the spirochetes in tissue, and in 1913, it was Noguchi who found T. pallidum in the brain of individuals with GPI. Noguchi, like John Hunter before him, actually injected himself with skin extracts and died of neurosyphilis in 1928. So he gave himself the disease. The early manifestations of GPI are irritability, memory loss, poor concentration, personality change, carelessness, headache, and insomnia. And the late manifestations are defective judgment, emotional lability, lack of insight, confusion and disorientation, delusions of grandeur. They think they're Napoleon, or I don't know, they think they're Donald Trump. Paranoia and seizures. Guy de Maupassant, a very famous French writer, had neurosyphilis. He wrote, "I am obsessed by women. I cannot pass up their caresses. And when a woman stops me in the street by chance, despite her fetid breath and repugnant filth, I cannot resist for long that silent and powerful call of the flesh that wells up like the waves from below." In 1873, he developed patchy alopecia, headaches, nervousness, insomnia, visual loss, and hypochondriasis. He states, "I assure you that I am losing my mind." He referred to his urine as diamonds. He felt that he was urinating diamonds. He was ultimately straitjacketed and institutionalized and dies 20 years later in 1893. The signs of general paresis include pupillary abnormalities, but the prototypical Argyll-Robertson pupils are seen in only about a quarter. Slurred speech is seen in 28%. The face may be expressionless. There are tremors of tongue, face, and hands. In fact, one of the things that I found in the few patients that I'd seen is how frequently I've observed a tremor of their tongue, which you don't see very often in too many diseases. The reflexes are abnormal in 52%, and less than 2% have focal signs, optic atrophy, extraocular muscle palsies, or extensor plantars. If you look at their brain, there's generalized brain atrophy. This, by the way, is a silver stain where you see the treponeme in brain parenchyma. The abnormalities chiefly in the frontal regions. The pia and arachnoid are thickened and opaque. There's a fine ground glass appearance of the ependema. It's chiefly seen in the floor of the fourth ventricle, and you'll find T. pallidum in the parenchyma if you look for it. Now, G. de la Tourette is another person who had neurosyphilis, the person who was responsible for naming Tourette syndrome. Actually, he was a student of Charcot, and Charcot, who had really described Tourette syndrome, said, Tourette, why don't you write this paper? But in 1901, Tourette was noticed to have a change in behavior. His hair was, he was developing alopecia. He had a voice, raspy and coarse voice. He had abrupt gestures, a grotesque demeanor. And one day he's found by his wife naked, cowering under a desk with a patient in the corner. He was ultimately placed in an institution. So some of the famous people that we're familiar with have a history of neurosyphilis. This was a patient that I saw. He was from North Carolina. He was a 22-year-old bisexual white man. In August 1990, he developed a generalized seizure. His examination was normal, neurologically, and his general examination was normal. He was seen at Duke University. He lived in that region. He was found to be HIV positive. His CD4 count was 227. Toxoserologies were negative. A CT scan of his brain, as you see here, revealed a right parietal contrast-enhancing lesion with edema. And the MRI showed the same thing, with meningeal enhancement and lesion enhancement. When they tapped him, there were 14 WBCs, 98% lymphocytes. The protein was 71, the glucose was normal, and all microbiologic studies were negative. His past medical history was interesting. He was sexually active since the age of 13, and at the age of 18 had been demonstrated to be HIV positive at the time of blood donation. He had no AIDS-related complications. He did not tell anybody about being HIV positive, and therefore received no medical therapy. And in February 1990, was found to be VDRL positive by contact tracing. He was treated with benzathine penicillin weekly for 3 weeks. They biopsied his brain because they didn't know what this was, and this is what they found: inflammatory infiltrates with lymphocytes and plasma cells perivascularly. He was started on zidovudine, and because they thought this may be toxo, they gave him sulfadiazine and pyrimethamine, and then clindamycin was substituted for sulfadiazine. In September 1990, his headaches were worse. He had recurrent seizures, and he developed left hemisensory and generalized seizures. And as you can see, the lesion is now much larger with more edema. They do a PET scan, the lesion's hypometabolic. They repeat the biopsy, it's polyclonal T cells. They do a VDRL, which is 1 to 64, and his FTA is positive. They put him on dexamethasone and aqueous penicillin. They repeat an MRI on December 31st, 1990, which is immediately before he gets on a plane to see me. So I see him in the week or maybe 2 weeks after, right after Christmas, right after New Year's. And guess what? The lesion's gone. And what he had was a syphilitic gamma. They just didn't recognize it for what it was. So this was syphilitic gamma causing seizures in a HIV-positive individual. Gammas can be seen in the parenchyma, but are often meningeal-based, as in our patient. Here's another New England Journal case that I thought was interesting because it was, again, unsuspected syphilis. A 58-year-old woman, a college professor who was monogamous with her boyfriend. So not somebody that you would typically think at high risk for syphilis. 4 years earlier, she had a history of a brown non-pruritic maculopapular rash with a peeling erythematous rash of her palms, which I showed you, by the way, earlier in another New England Journal case. But she also had oral and nasal aphthous ulcers that resolved, which raised concerns about Behçet's disease. 3.5 years earlier, she had bitemporal pingueculi and conjunctival ulcerations, was diagnosed with uveitis. She was HLA-B51 positive, so they thought, oh, this must be Behçet's disease. And they started her on rituximab, adalimumab, cyclophosphamide, and steroids ultimately. She develops persistent eye pain and headache. The eye pain shows panuveitis. A CT and MRI of her head are normal. Spinal fluid, however, does show 64 WBCs, 63% polys with a high protein. A punch biopsy of the rash shows T. pallidum, and her serologies are 1 to 16. So this is the rash that she had. It's on her legs and on her hands, and it proved to be just syphilis. This was a patient I saw at Penn. This was a 32-year-old gay man, a former dancer who had been celibate for 3 years. He presents in February 2015, being brought to the emergency room by his family because he was dysarthric and had unsteady gait. He had a change in his speech over 2 months. Clumsiness began months earlier, and he had concomitant impaired cognitive function. On examination, he had a fluent dysarthria with scanning speech. He was unable to spell world backwards. He had no Argyll-Robertson pupils or optic atrophy, but he did have slight dysmetria on finger to nose and heel to shin testing and an ataxic gait. There was this funny movement of his feet, which was described as being myoclonic. He had a tongue tremor as well as equivocal plantars. And this was his MRI. So you look at this, and the insula and the temporal lobes are hyper intense, and you'd say, oh man, this guy's either got herpes encephalitis or he's got an autoimmune encephalitis. And it turned out that this was simply syphilis. His screens for autoimmune, his autoimmune panel was negative. And by the way, I'd say that the Penn autoimmune team is among the best. Joe Dalmau was here for many years before he moved to Barcelona and still has a joint appointment. And we still have a very good team for autoimmune disease. So we didn't find him. His spinal fluid showed 38 WBCs. His VDRL was positive in the spinal fluid, as was TPA. His protein was elevated. HSV PCR was negative, and his RPR in the periphery was 1 to 1240. He was treated and got better. Syphilis can also affect the spinal cord, and it can affect it in many different ways. So this comes from a book chapter that I wrote. It's probably 80 pages, and it's in Syphilis of the Spinal. It's in Davidoff's textbook of the spinal cord. You have an acute myelitis, a chronic myelitis, something called syphilitic meningomyelitis or herb spastic paraplegia, which, by the way, is the commonest form of spinal cord syphilis I've seen. Spinal cord infarction due to vascular involvement, syphilitic poliomyelitis, TABIes, compression of the spinal cord by the vertebral osteitis or Charcot's vertebrae, syphilitic pachymeningitis with gamma or hypertrophic pachymeningitis, syphilitic aortic aneurysms involving the spinal cord, and syringomyelia. TABIes, however, is the prototypical spinal cord disease. It was referred to by Duchenne as locomotor ataxia. It accounted for 1/3 of all neurosyphilis in the 19th century, and now is clearly well under 5%. Only about 2/3 of people will have a history of prior syphilis, so 1/3 to 1/2 do not. The latency to development is on the order of 10 to 15 years, and the average age of onset is 40 years. It is more common in men than women, but I must say that's not been my experience. I've seen it as often in women as I have in men, and it occasionally occurs with other neurosyphilitic manifestations. There are several stages. The first stage is preataxic. It develops early and lasts about 3 years. It is during this time that people first develop the crises or severe pains. There are other subjective disturbances such as weakness and fatigue, difficulty ambulating in the dark, vertigo, and diplopia. They have loss of reflexes, diminished vibratory and position sense, more of that than they do loss of pin and temperature. They have hypalgesia, so pain is not perceived well, and that's the derivation of a number of eponymous signs like Abadi's, Bernanke's, and Petra's, where you squeeze the Achilles tendon or the testicles and people simply don't feel it. Romberg test is present in 90%. In fact, Romberg developed the test to find people with TABs to keep them out of the Prussian military. And Argyll-Robertson pupils are common. In the ataxic phase, this lasts between 2 and 10 years. It averages 4. The ataxia predominates. There are tabetic pains, which may worsen during this period, and sensory perception abnormalities are common. People describe a sense of being wrapped in cloth, as one sees very often with diseases of the posterior columns. The arms are generally relatively unaffected. In the terminal phase, or the third stage, which lasts between 2 and 10 years, the legs are stiff and paralyzed. There's generalized debility with emaciation. Autonomic dysfunction predominates with obstipation, anorexia, and loss of sexual potency, and a death from sepsis due to pyelonephritis or decubiti ulcers. Give me 1 second. My daughter's fiance is an opera singer and he's teaching a class. I'm just going to shut the door. That's the singing in you here in the background. Sorry about that. You may be serenaded during this. TABs is associated with a variety of symptoms, the commonest of which are the lightning pains. Ataxia is seen in 42%, bladder disturbances in 33%, paresthesias in 24%, and so on. Signs include pupillary abnormalities in 94%, but only a half have Argyll-Robertson. Ankle jerks and knee jerks are lost because the dorsal roots are involved. Romberg test is seen in 55%, impaired vibration in 52%. Ocular palsies in 10%. So this actually comes from Charcot. Actually, this picture here is from Charcot. Charcot, as you recall, was the chief neurologist at the Salpêtrière. Can somebody mute Could everybody mute their computers? Thanks. So this is from Charcot. He was one of the people that popularized, if not the person that popularized, the use of medical photography. This is a woman. Mind you, Charcot, when he examined people in the amphitheater, he made them take off all their clothes. That's why she's naked. And she's got a cane on one hand and an umbrella in the other, and she's got Charcot joints of the knees. This is perforation because they can't feel the bottom of the feet. They slap the bottom of their feet, and they can develop hypermobility of their joints. So it almost looks like they have Ehlers-Danlos syndrome. Oculomotor palsies can occur in association with TABs. This comes from Frank Wolf's series. And this is the treatment that was administered to Alphonse Daudet. This comes from a paper that Doug Lanska, who was in my department at the time, wrote, where he describes the treatment of Alphonse Daudet's Tibetic crisis with the suspensory treatment that Charcot employed. And Daudet was very articulate, of course, a writer, and he wrote about this pain. He said, sometimes under the foot, a fine cut, a hair, or else a knife thrust under the toenail, the torment of a spiked boot, rats with sharpened teeth gnawing my toes, crucifixion, the torment of the cross, twisting my hands, feet, and knees, my nerves strained and pulled to bursting point, and the rough cord constricting my trunk, the sword thrust in my side. The treatment did do a damn thing for Daudet, and it also ended the friendship between him and Charcot. So this is from Abraham Ornstein. Ornstein popularized videography, and these were from a series of videotapes that he took at Philadelphia General Hospital between 1927 and 1936. The voice is that of a former colleague of mine at Penn, Bill Banks. So this is the Tibetic gait.
He captured the ataxic gait of Tabes dorsalis.
And this is the Tibetic crisis.
And the violent leg movements associated with Tibetic crisis.
This is actually a patient of mine. I don't know, in the interest of time, I may not show the whole thing. But this was a patient of mine who I saw in Lexington, Kentucky, who had been from New York. She'd come down to Kentucky to care for her grandchildren. And she had a history of, like this other patient I told you about, of being treated with benzathine penicillin, and it proved to be insufficient because she subsequently developed Tabes dorsalis and came to see me because of gait abnormalities and pain. And you could see that she's got some dysmetria on heel-to-shin testing. She's got an ataxic gait. She had a history of being a former crack cocaine user. I told you earlier that that was common in people with neurosyphilis in our country. All right. So the changes in Tabes predominate in the posterior columns, the dorsal root ganglion, the posterior nerve roots. You'll see that the cord is atrophic. The dorsal columns become demyelinated, and you lose your reflexes because of the involvement of the posterior nerve roots. The meninges are typically thickened, and the lower thoracic and lumbosacral areas are most involved. This syphilitic meningomyelitis is a bit more common in my experience. You usually see it between the ages of 25 and 40, although I had a 60 or 70-year-old Cuban man who was quite a good dancer and was unable to dance as a consequence. And after we treated him, he returned to the dance floor. A little more common in men than in women, gradually developing lower extremity spasticity. They can have Brown-Séquard with it. They complain of a heavy sensation and weakness in their legs, paresthesias and a girdle sensation, and are noted to have a spastic weakness. This is another one of my cases, and in the interest of time, it's reported in the American Journal of Medicine from 1992. In the interest of time, I won't go through it. Suffice it to say, however, that after treatment, this lady also returned to walking normally. So it's important to make this diagnosis and to make the diagnosis early. This comes from Ahmad Bigji, who's in South Africa. These are pictures of spinal cord syphilis on MR. How do you diagnose it? Well, if you look, there are two forms of test. You have the non-treponemal test and the treponemal test. The non-treponemal test, the first was, of course, the Wasserman. But we now have the VDRL or RPR. The Reagan and Colmer are rarely used, at least in the United States. In primary and secondary syphilis, the rates vary. So in primary syphilis, the VDRL is positive only 70% of the time, and the RPR 80% of the time. In secondary syphilis, it's present 99% of the time. But when you get out into late syphilis, And in tertiary syphilis, the rate falls to 70%. And therefore, you can miss a third of patients that have neurosyphilis, tertiary neurosyphilis, if you're relying on a serum VDRL or a serum RPR. It will not be positive. The FTA-ABS, on the other hand, or the MHATP, do remain positive even after treatment, and therefore are the tests to employ when you suspect a patient may have neurosyphilis. There's something called the prozone phenomena. I put this in because one of my residents asked me about it. It appears to be more common with HIV and with neurosyphilis, and it's a false positive RPR because your antibody titers are so high that it interferes with the test. The spinal fluid, there are a lot of things that are non-specifically abnormal, including cell count protein, IgG, and oligoclonal bands. But you want to look for the VDRL. So generally the VDRL is positive, though there are instances where the VDRL is not. And you can look at things like IgG synthesis in the spinal fluid relative to the serum, or you could do a polymerase chain reaction for T. pallidum in those cases where you have a high index of suspicion. And this is a paper by Christina Mara, which addresses diagnostic measures that may be employed. I refer you to it. She's truly a world's authority. In the setting of HIV infection, it can be quite difficult to determine because individuals might often have abnormalities in their spinal fluid from the HIV that parallel the abnormalities we see in neurosyphilis. For instance, an elevated CSF IgG and elevated oligoclonal bands. So individuals that have definite neurosyphilis, this comes from an AIDS clinical trials group protocol that we put together, had reactive VDRLs, but if their VDRL was not reactive, if they had a pleocytosis and elevated protein and features consistent with neurosyphilis, we called it probable neurosyphilis, and if they had these abnormalities in association with a reactive treponemal serum test, but no neurologic abnormalities, we called it possible neurosyphilis. Now, a difference in the expression in the immunosuppressed should be anticipated because this paper from 1957, when Hollander and Turner were putting treponema pallidum into the skins of rabbits and then looking what happened, found that if you treated the rabbits with high doses of cortisone, you found that these lesions became very, very large, swarmed with treponemes, unlike what they had ever previously encountered. This gives you a frequency with which one saw neurosyphilis with AIDS. This comes from my study, where we found it just under 2%. In Brazil, it was almost 6%. Now, this is in the era before the introduction of highly active antiretroviral therapy and wide adoption of safe sex practices. But in general, neurosyphilis is not uncommon in HIV. It's generally a younger patient. They often have a history of syphilis. Eye problems, rash, and features of secondary syphilis are common. They have a greater pleocytosis, a lower glucose, and often have syphilitic meningitis and meningovascular syphilis early in the course of their disease. The disease is clearly modified as a consequence of HIV infection. There's a shorter latency to the disease, higher rates of meningitis, meningovascular syphilis, eye and skin disease, and we'll more often see diagnostic problems and treatment failures. How do you treat syphilis? Well, the standard treatment is aqueous penicillin, 2 to 4 million units every hour. I should say every 6 hours for 10 to 14 days. Amoxicillin could be an alternative with probenecid. Ceftriaxone and doxycycline have also been employed. What you'll see is a fall in the serum VDRL, a 4-fold fall in 3 months, 8-fold in 6 months, non-reactivity in treatment for primary syphilis by 1 year, secondary syphilis in 2 years, and latent syphilis in 5 years. What about the CSF? Well, you should be looking at the CSF. It should normalize within 6 months to 2 years. However, be aware that in the immediate aftermath of treatment, just like you could have a Jarisch-Herxheimer reaction with the administration of penicillin, you may have an increase in cell count and an alteration in protein. The protein generally normalizes by 2 years, and typically the CSF VDRL parallels that in the serum. So I'll leave you with this thought by Erasmus. If I were asked which is the most destructive of all diseases, it is that of syphilis, which for some years has been raging with impunity and so cruelly tortures the patient. What contagion has ever extended so quickly to all the countries of Europe? What contagion does thus invade the whole body? It combines pain and the danger of death. And I'll stop there and take whatever questions you have. Thank you very much.
Thank you, Joe, for a wonderful talk. And I'm sure we had around 300 people listening to you from around the country. And there are some questions. So before I take their questions, so if I have to ask, if somebody presents with myelopathy, so it will be like a spastic ataxic myelopathy?
Yeah, so generally you'll see spasticity, particularly with the herb spastic paraplegia, which is the syphilitic meningomyelitis that we generally see. The other forms that we see, even with tabes dorsalis, you might find some increased tone, but the reflexes may be diminished. The tone in the people with tabes has been quite variable. So it may be, their tone may be diminished, it may be normal, it may be increased. Generally, they're areflexic, and they may or may not have Babinski signs. But the other forms of neurosyphilis, so the vascular forms, the gummatous forms, where you get the meninges become very thickened, pachymeningitic picture with the squeezing of the spinal cord, or a gumma compressing the spinal cord, or syphilitic osteitis compressing the spinal cord, or lastly, this meningomyelitis that I've described, generally is associated with a spastic weakness in the lower extremity. So there's increased tone, brisk reflexes, and upgoing toes.
So other thing people are asking it, a patient who has an HIV and syphilis both positive.
Yeah, both are positive. If there is that the question?
No, yeah. No, it's a scenario. So in that case, is myelopathy will be like HIV myelopathy, which is more like SSCD, or spastic myelopathy, which is more like syphilis?
So I don't think I've seen somebody who's had a myelopathy who's had both infections. I just haven't, except for that one prostitute that I described, I haven't seen it otherwise, I don't think. And that was somebody who presented with spastic lower extremity weakness.
Okay. So if I get you correct, the MRI finding, if there is a lot of pachymeningeal involvement, that will
there can be. So the MRIs of somebody with neuro, are we talking about spinal cord syphilis, or are we talking about spinal cord? So it depends on what the underlying pathology is. So there could be meningeal involvement. Okay. It could be parenchymatous involvement without meningeal involvement. It could be both. Yes. It could look like an infarct of the cord. It could look like transverse myelitis. It's quite variable.
Okay. So shall I take questions from the audience?
Yeah, there are lots of questions. Maybe some Rahul can take. For example, Rahul. Dr. Priyank Shah is asking about the CSF.
I made a PowerPoint-like presentation if you want me to run through the slides.
Oh, wonderful, wonderful. Yeah.
Yeah, okay, good. Let me see if I can pull it up.
Joe will have to stop the screen.
Oh, yes. Stop share. Okay.
Yes.
Oh, there it is. Okay, good. Good. Okay. All right, so prophylaxis for asymptomatic patient with CSF VRL positive. So somebody who has a VRL that's positive in the spinal fluid has, by definition, neurosyphilis. And that person needs to be treated with high-dose intravenous penicillin, aqueous penicillin, for several weeks. So it's only prophylactic, and to the extent that you're trying to prevent them from developing any symptoms. But by definition, they have neurosyphilis.
Yes.
All right. What's the mechanism behind
There are 3 questions into this.
Yeah, so should be aggressive as acute bacterial. All right, so I'm not sure what the answer is for the first question, because I'm not sure what the question is referring to, but the lancinating pains are the consequence of the involvement of the nerve roots, the dorsal nerve roots, by the bacteria. And it becomes quite inflamed with a meningeal inflammation around the nerve roots. So I think that largely explains it. I don't think it's necessarily from involvement of the parenchyma, either brain or spinal cord. Because the organism is different than other bacteria, you know, I think that the way it presents is really quite different than, say, Neisseria meningitidis or Haemophilus or pneumococcus. You know, the way these the way the body responds to organisms varies with the nature of the organism. So, for instance, fungal meningitidis, they can go on for long periods of time without there being any acute manifestations or very much in the way of anything. And I think for whatever reason, T. pallidum lives symbiotically with the host and often causes little in the way of problems for long periods of time, if not indefinitely.
Yes.
So the question is, which is, elderly male with 2 years history, cognitive behavior. Clinically predominant frontotemporal dysfunction, generalized atrophy. Yeah, so I don't think you, so I suspect that statistically he probably has frontotemporal dementia. However, I don't think you can say with certainty that it's not syphilis. I think that a CSF FTA might be of interest. I think if you can get a CSF PCR, that would be of interest. But despite those tests, I think that in the interest of being complete, I would treat this man as if he has neurosyphilis. I would, because you wouldn't anticipate 15 cells with frontotemporal dementia or some neurodegenerative process, and even the protein's high. So my belief is this is presumptive neurosyphilis. I treat him as if it's neurosyphilis, and even if it isn't, you have little to lose.
How common is false positive serum VDRL?
So the false positive, so you do see false positive VDRLs and RPRs, but the MHA-TP or the TPHA should be pretty specific. So I don't think, you know, you have that. So I don't think that it's very likely that it's false positive.
No, serum, not CSF, serum.
That's what I'm saying. You have an FTA-ABS or MHA-TP in that case that was positive in the serum.
Yes.
So that patient had syphilis. Okay. So which is more sensitive? So it turns out that the VDRL is IgM, the FTA is IgG. So IgG will cross the blood-brain barrier much more easily than IgM, which doesn't cross the blood-brain barrier. And therefore, you will see the FTA-ABS positive in individuals that don't have neurosyphilis. They have syphilis, but they don't have neurosyphilis. So if you say, which is more sensitive, I'd say, well, the FTA-ABS is more sensitive. However, it's far less specific. So the Argyll-Robertson pupil is generally bilateral, but it can be unilateral. Which patient will we get false positive CSF VDRLs? I'm unaware of any patients. I shouldn't say that. It's got to be extraordinarily rare to see a false positive CSF VDRL. By definition, if you see a VDRL that's positive, that's regarded as neurosyphilis. Having said that, I will tell you that many years ago, probably in 1981 or 1982, I had a young woman who came to see me with a seizure disorder. And in the process of working her up, she had abnormalities on a brain MRI. And in the process of working her up, I thought she might have I did a spinal tap, and the CSF VDRL was positive. And I thought she was going to turn out to have a gamma. And in fact, I went to the operating room with my camera to take pictures of this. And it turned out that she had a glioma and that the CSF VDRL was falsely positive. I think. I mean, she also had a serum VDRL that was positive. So she might have had syphilis and a glioma. I don't know. Which cases of optic neuritis is it required to send CSF VDRL every time? I think when you have individuals that have serologic evidence of syphilis, that you should send a CSF VDRL, regardless of whether they have optic neuritis. You want to know whether they have asymptomatic neurosyphilis. But in the absence of there being serologic evidence of syphilis, then you don't have to worry about the optic neuritis being due to syphilis.
Yes.
In which type of patients of stroke is CSF VDRL? So the same story. If you do a serum RPR, unless there's a high risk, a large concern where you'd want to do an FTA-ABS, you know, a gay man, for instance, or somebody who's very sexually active or a history of sexually transmitted diseases, I think that an RPR is probably sufficient. If it's negative, in the absence of there being any other reason to do it, an FTA-ABS, I think that's probably sufficient to say, I don't need to do a CSF VDRL. On the other hand, if you're tapping somebody, I would always add a VDRL. And in fact, one of the things that we've gotten away from in the United States, and I think is a mistake, is doing an RPR when the patient first comes into the hospital. I mean, we used to do that, chest x-ray and CBCs, but we don't do that anymore as routine, and an EKG. Which type of cognitive impairments? So really it could be any form of cognitive impairment, but something that develops in the absence of there being a family history of psychoses, when an adult individual starts developing psychotic manifestations, paranoia, delusions of grandeur, I would think that that's somebody that I'd be very concerned might have syphilis. And I think that, once again, with respect to the last question, should we do CSF VDRLs in everybody with these things? I would argue that if your serologic evidence, if there's no serologic evidence of syphilis, there's probably no reason to do a CSF VDRL.
Okay, there's one very interesting question. I want, before, you know, I don't want to get left out. So Dr. Meshram says, artists with neurosyphilis had their best creativity during early phase of neurosyphilis. Explanation and comments. With control of syphilis, is the world losing the best of art?
Yeah, well, I don't know. I'm not about to catch it to find out.
I know only
besides,
one.
I'm too old. I'll never develop neurosyphilis at this age.
Who are the other artists? I think.
But it's an interesting observation. You know, Bruce Miller, I think that it's Bruce Miller, has described the creativity of people with frontotemporal dementias. As you become increasingly demented, there's this creativity that's unleashed. Obviously, at some point in time, it diminishes because of the severity of the dementia. So could there be some, I think it's an interesting observation. I don't know if it's true or not, but it's an interesting observation, and were it true, my argument would be whatever's unleashed in the frontotemporal dementia patient is probably the thing that's being unleashed in the person with GPI.
Everything has some plus point and minus point, and I think even COVID has some plus points and minus points. It is resetting the whole world.
There you go.
Okay. Rahul, Vinay.
Yeah, so you would anticipate finding a normal CSF in vascular syphilis. You'd see a positive VDRL, an increased protein, maybe a few cells. For the life of me, I can't remember seeing a patient with normal pressure hydrocephalus that turned out to have neurosyphilis. I imagine that it occurs, but I just don't remember ever seeing one. Orbital super, that's interesting. Whoever's writing these questions should write up these cases, because every year I go through the latest literature on neurosyphilis and I update a chapter that's published online in MedLink. And I cite these weird things so that people know to look for them. So you guys need to write these up. And by the way, send them to the Journal of Neurovirology, which even though it says Journal of Neurovirology, it's a journal of general infectious diseases.
I just, because we had this, I want to tell that when I was a student, Dr. Wadia, my teacher, gave me a thesis for studying Tolosa-Hunt syndrome. And the first patient we had, we said this is classic Tolosa-Hunt. The person had one side of the third nerve, then after improved with steroids, a few days later, other side. And then at that time, there was no MRI. We did an MRI angio the next time, and CT angio, and not only CT angio, sorry, routine angio. There was no CT scan, no MRI at that time, and we found the thing was opened up and he had actually a tumor there. The second patient, I said, this is classic, this one is classic Tolosa-Hunt and syphilis. Then I said, I'm not.
They're great cases.
Yes.
Yeah, so we talked about this. It could be virtually
Yes, we talked about this. Yes.
This also be finished, I think.
So yeah, we talked about that. Cognitive profile of neurosyphilis. Well, that's in the slides.
Yeah.
Thanks.
Just be done.
We talked about what's the mechanism.
So I think, Vinay, can you take up the further questions?
No.
I done up to, I think, 40s, so maybe a few more.
We've done these questions.
Yeah.
Yes.
Few more questions. Do you want to take few more questions?
Are there any questions now? I think
there are few more. I done it while the lecture was ongoing, so there are some questions which
go back down.
Yeah.
Why do you get Charcot joints when there's so much pain in Tabes crisis? I mean, if there is sensory loss, and then why?
We're talking about two different things. So the crises that people have is pain that comes on spontaneously. It's not the consequence of you touching the skin or tenderness or anything like that. It's just this severe pain that is usually visceral, but can be in the extremities. The loss of pain, however, is the consequence of involvement in the dorsal root ganglia. It's like they're being severed. So they're actually these eponyms that I've talked about where in the late 19th century, people developed tests that would help them determine whether somebody had syphilis or not. And among the tests were squeezing testicles. You know, if the guy didn't scream in pain, you go, oh my God, that's got to be, or you squeeze the Achilles tendon, or you did something else. So they all had names associated with them. So you don't have pain. You don't know where your feet are because you have position sense loss. You're atactic. You don't know where your feet are. You're constantly slapping them down like this. And as a consequence, you develop these ulcers on your feet, and you develop degenerative changes in your ankles, knees, and hip. And even in your spine, you can develop the degenerative changes.
Why is there any other disease which causes this Tabes dorsalis-like symptoms? Nothing else that we know of. I mean, what is so specific about this organism?
Yeah. Yeah, I wonder if, and you guys probably see, well, I'm sure you've seen a lot more of it than I have. How about in the lepers?
The leprosy, we don't get crises there. We of course get...
no, I know you don't get crises, but what about Charcot joints?
We get
yeah, we do get Charcot joints, but not like this. They're mainly distal ones, not the proximal ones.
Yeah.
Yes. Not the large joint, maybe small joints. because of trauma, and yes. Not like knee, which you showed a wonderful picture here.
Diabetes, you can see Charcot joints in.
Sorry?
Take a few more questions.
No more questions.
You want to ask about the imaging features of cerebral gamma, and
We saw that picture, beautiful
most of the
picture.
time the things we have picked up.
Yes.
Mimicking FPD. Okay, I think Joe will let
Vinay, you know what? You have a picture of the Golden Gate Bridge behind you. Next time, I'm going to have a picture of the Taj Mahal behind
Yes, I
me.
was going to say Taj Mahal. but Joe, to get that, your background has to be very plain. Otherwise, it doesn't come. This virtual background doesn't work unless you have a plain background. I tried
I
to do.
see.
Okay.
So Vinay is the only one who's managed that.
No, somebody helped me from the desk how to do it. I was not able to do it earlier. So today it worked.
Thank you, Joe. And I want your next talk is also going to be scintillating. We are all going to enjoy it. I want to tell people in advance, so let me know when you want to do CJD, because that is one topic which all neurologists are interested in.
Yeah.
All right. Well,
yeah, you can email me.
The weekends and Monday work best for me. I actually am still working.
Okay, I'll email you. We'll book.
Yeah, we'll figure it out.
Okay, thank you.
All right,
Vinay.
guys.
Thank you.
Thank you.
Thank you, Joe.